All right, let's talk about a clinical reflex that is so deeply ingrained in medicine, but one that the evidence tells us we really need to rethink. We're talking about treating asymptomatic bacteriuria. Let's kick things off with a scenario you've probably all seen. So, picture it. You're on call, you get a page. An 82-year-old patient took a tumble. As part of the usual workup, a urine sample was sent off, and it comes back positive for bacteria. That knee-jerk reaction for so many of us is to just reach for the prescription pad. But hang on, is that the right move? And that reflex right there, seeing a positive lab and immediately treating it, is a massive, massive contributor to antibiotic overuse. We're talking about a huge driver of resistance and, believe it or not, patient harm. So today, we're going to build a really solid evidence-based framework for when to treat and, maybe more importantly, when to resist that urge. To get this right, we have to start with the most fundamental distinction of all. What's a real urinary tract infection versus, well, what's just some bacteria hanging out in the urine? Asymptomatic bacteriuria, which we'll call ASB, has a super clear definition. It's when you find a significant amount of bacteria in a properly collected urine sample from a person who has absolutely zero symptoms of a UTI. The key word here, the one we have to burn into our clinical brains, is asymptomatic. Now, this is where we really separate the signal from the noise. True UTI symptoms are specific, right? It hurts to pee, you have to go all the time, you've got pain over your bladder. They point directly to the urinary tract. But then you have this other list, delirium, falls, just feeling kind of blah. Those things are incredibly common in older adults for a million different reasons. And if you don't have those specific urinary symptoms, we should have a really high bar before we start blaming a positive urine culture.
Okay, here it is, the big one. I can almost hear you thinking it. This is the most common pushback you'll get. But wait, there's pyuria. Look at all the white blood cells in the urine. That must mean there's an infection we have to treat.
So let's be crystal clear on this, because the guidelines couldn't be more direct. Pyuria does not equal a UTI. It's actually really common in ASB, and you can even have it without any bacteria at all. Just think of it as some sterile inflammation. The bottom line is this: pyuria without those specific UTI symptoms we just talked about is not an indication for antibiotics, period. Full stop. So we've established what ASB is. Now let's get into the really powerful evidence that shows why, for almost everyone, treating it is absolutely the wrong move. This is really the whole story in a nutshell. Treating ASB doesn't help patients, and in fact, it can actively hurt them. Let's look at the data. Okay, so what's the number one reason we think we should treat ASB? It's probably to prevent a future actual symptomatic UTI, right? Makes sense. But as this meta-analysis shows, that's just not what happens. Treating ASB has zero statistically significant effect on stopping a real UTI down the line. That risk ratio is basically 1. You're not preventing anything. So there's no benefit, but is there any harm? Oh yeah, there's definite harm. Patients treated for ASB have a nearly 4 times higher risk of adverse events just from the antibiotics themselves. We're talking about side effects, organ toxicity, and of course the dreaded C. diff. We are actively exposing our patients to real risks for literally no gain. And here it is, the public health disaster in a chart. When you treat ASB, you are basically training bacteria to be resistant. So when that same patient later gets a real UTI, the bug causing it is way more likely to be a tough one. Just look at Cipro resistance. It more than doubles from 19% to 44% in patients who were treated for ASB before. We're making future infections much, much harder to treat. So let's just recap the damage report. Treating ASB doesn't prevent UTIs. It doesn't reduce mortality. It does cause side effects. It definitely drives resistance. And some data even suggests you might mess up the bladder's natural microbiome, potentially making future infections more likely. It is all harm, no benefit. Now, like any rule in medicine, there are a few exceptions. But for ASB, I want you to remember that they are very specific and the list is very, very short. These are the guardrails for our clinical thinking. These are the only 3 situations where screening for and treating ASB is recommended. Number 1, pregnancy. That's because of the risk of pyelonephritis and bad outcomes for the baby. 2, before a urologic procedure where you expect to cause bleeding, like a TURP, to prevent bacteria from getting into the bloodstream. And 3, in certain protocols for patients who have had a very recent renal transplant. That's the entire list. That's it. Now notice who is not on that list. older adults, patients with diabetes, patients with catheters in, patients about to get a hip replacement. For all of these incredibly common groups where we see ASB all the time, treatment is not recommended.
Okay, so let's pull all of this together into a simple, actionable mental model that you can actually use on your next shift.
This table right here, this is your guide. The most important thing is to always start with the patient, not the lab slip. Ask yourself, does this person have specific urinary symptoms? If the answer is yes, great, treat them for UTI. But if the answer is no, they are asymptomatic and you do not treat, unless they are one of those 3 very specific exceptions. And remember, as the table shows, pyuria doesn't change that. A fall or delirium doesn't change that. In those cases, the positive urine is almost always an innocent bystander, and you need to keep looking for the real cause. Resisting that urge to treat a lab result is just better, safer, evidence-based medicine. You're protecting your patient from harm, and you're doing your part to fight antibiotic resistance. So the next time you see that positive urinalysis, just take a breath, go see the patient, and remember to treat them, not the test. And that leaves us with one final thought. Now that we've got this down, what's the next clinical reflex that we need to challenge?